Good afternoon and welcome to the University Center for International Studies, to the European Union Center of Excellence at the University of Pittsburgh. I'd also like to thank our co-sponsors here in USIS, including the Global Studies Center and the African Studies Program, as well as some co-sponsors outside of the University of Pittsburgh, among them the European Union Center at the University of Illinois, and their colleagues at the Center for Global Studies, the Center for African Studies, the Global Health Initiative, and the College of Liberal Arts and Sciences Global Studies Program, all at the University of Illinois, Urbana-Champaign. I'd also like to welcome our colleagues in Miami, Florida, at the EU Center at Florida International University and the University of Miami. The topic for today's virtual roundtable, as part of our ongoing Conversations on Europe series, we'll focus on the recent Ebola epidemic, or at least we'll start with a focus on the Ebola epidemic and the European Union's response to the crisis. But then we're going to pan out and we're going to look back in time to discuss past examples of European responses to other diseases, particularly those diseases that were seen to have their origins in Africa and that Europeans most often encountered when they ventured into the colonies, or diseases which encountered Europe and Europeans when they traveled overseas and across borders through European trade and imperial movements of goods and people. Now, you're welcome to join the conversation, and we're going to put up a slide and share that content. If you'd like to ask a question, we are going to be taking questions via Twitter. Just tweet your questions at EUCEESC, #PITCOE. You might also want to follow us on Facebook to be alerted to when this video is posted and other events that we're having in the same series. And of course, you can watch and share the video once it's posted on the PIT USIS YouTube channel. So that information is up there. I'm going to take a minute to introduce our panel of experts, which I think after I've introduced them, you'll all agree that they are the perfect people for discussing this particular topic. On my left first, I have Mary Wabel, who is Assistant Professor of History, and this is her first year at the University of Pittsburgh. She came to Pitt from a postdoc at Emory University as a fellow in African Studies and in Global Health, Culture, and Society. Dr. Wabel's teaching and research focuses on the history of global health, disease and health in modern Africa, and in particular, on medical practices and politics surrounding sleeping sickness prevention and control in colonial East Africa. Guillaume Lachenelle, who's over there, is a faculty member in the Department of History and Philosophy of Science at the Université Paris Diderot, whose research interests focus on the history of medicine, global health, and colonial medicine in Cameroon. He's the author of several books and articles, including a monograph entitled Le médicament qui devait sauver l'Afrique, un scandale pharmaceutique aux colonies, which I really just wanted to say because I wanted to speak French for a minute. Jessica Pearson-Patel, there you are, Jessica, is Assistant Professor in the Department of International and Area Studies at the University of Oklahoma. She too recently came to Oklahoma from a postdoc, this one at Tulane University. And her main research interests include global public health and colonial politics, and the role of international organizations in the politics of public health in the post-war period. Last but not least, Deborah Neal is Associate Professor in the Department of History at York University in Canada. Her research focuses on the history of colonial medicine and humanitarianism and the role of transnational ties between tropical medicine specialists in Africa and Europe in the early 20th century. Thank you all for joining us. We really look forward to the conversation today, and I know you all have either met or read each other's work or known about each other in the past, so I think it's going to be a nice collegial and international panel discussion, so I'm really looking forward to it. I'm going to talk just a tiny bit longer, because I want to set the stage for the present before we dive into the past. So we start with, this conversation sort of was inspired by what's been happening recently in the media and in international responses to the recent Ebola epidemic. As you probably all well know, Ebola or Ebola hemorrhagic fever was the alarm first sounded a little over a year ago, in March 2014, after an outbreak was announced in Guinea in Western Africa. And by the end of March last year, it had crossed into Liberia and into Sierra Leone by May. In June, Médecins Sans Frontières declared the crisis to be out of hand. In August, the United Nations Health Agency declared that the virus constituted a, quote, international public health emergency. As the disease continued to spread into Nigeria and Senegal by the end of the summer, by September, the Director General of the World Health Organization said that it was spreading faster than the WHO's capacity to manage it. The first case of the virus in the U.S. made headlines in October of 2014. I'm sure you all remember that. But the disease was quickly contained, as was the first person to contract the virus outside of West Africa, a Spanish nurse. But again, in Spain, the disease was quickly contained. Germany, Norway, France, Italy, Switzerland, and the UK have all treated patients in their country who contracted the virus in West Africa and were flown to Europe for treatment. Now, more than a year later, as of the most recent figures I found were for April 8th, 2015, more than 10,600 people had been reported as having died from the disease in 6 countries. And this is in order of hardest hit, basically. Liberia, Sierra Leone, Guinea, Nigeria, Mali, and the US. The total number of reported cases is over 25,500, and probably significantly over. Most experts agree that just figures are likely underestimated. Now to the European response. According to the EU's official releases, the European Union's response to the outbreak has involved contributions of humanitarian aid, expertise, international coordination, and longer-term development assistance. In practical terms, what that means is the European Commission and EU member states have collaborated within the Health Security Committee to coordinate approaches on prevention and preparedness. The European Centers for Disease Prevention and Control, the ECDC, like our own CDC, and the World Health Organization produce, among other things, risk assessments, epidemiological updates, and advice to travelers. The EU and its member states have contributed over 1.3 billion euros, by their own accounting, to combating the disease, and another almost 140 million euros to a research program funded through Horizon 2020's research program to specifically support research into treatments, vaccines, and more effective and quicker diagnostic tests for Ebola. Last month, the EU organized a conference on the Ebola epidemic that focused on 2 main goals: taking stock of the ongoing emergency and the international response to it, and planning for the long-term support to recovery in affected countries, including the development of national health systems. I think it's interesting to note that the conference, which was organized by the EU and prompted by the EU, was co-chaired by the EU, Sierra Leone, and Liberia, the UN, the African Union, and the Economic Community of West Africa, which continues the EU's sort of contemporary approach. This differs from their imperial approach when Europe had an imperial past. And the contemporary approach to development policy, which emphasizes international and trans-regional cooperation and burden sharing by a variety of stakeholders within Africa. That's a little bit of the contemporary background. We have a panel of historians, though, so now we get to get into the fun stuff as a fellow historian. Yeah. And I sent our panelists a few questions to get them thinking. And I wanted to start with an image that appeared in Newsweek, which I'm going to put up and share because it generated a response. It was the cover of Newsweek, and it generated a response from political scientists writing for the Monkey Cage. Mm-hmm. And it was the Newsweek cover in August of 2014 that had this picture of a chimpanzee and the provocative headline, "A backdoor for Ebola, smuggled bushmeat could spark a U.S. epidemic." In their piece for the Monkey Cage, political scientists Laura Say and Kim Yi-don called out several examples from the Western media, but this was the one that sort of inspired it, that they described as part of, quote, the long and ugly tradition of treating Africa as a dirty and diseased place, end quote. So, and you know, there's some coverage of the same thing in the UK and in Sweden, and that was where that was. So I wanted to ask my panelists, just to start off, and as a way of kind of segueing into the past, would you agree that this tradition exists, and can you provide some other examples? And I think I'll start with Mary, because you're sitting right next to me.
Because I'm here.
Yeah.
I'll apologize in advance. I have a little bit of a lingering cough, so I am hopefully be able to speak consistently. Certainly for historians, I think one of the most striking things about coverage of the Ebola epidemic, leaving aside for the moment the historical factors that have contributed to the epidemic as it is right now, is that this in particular, this West African context is one that has a very long tradition in the European mindset of being particularly pathogenic, particularly bad. In the 19th century, Sierra Leone specifically was known as the, quote, white man's grave because of the high mortality rates of European soldiers going to those areas due to a variety of fevers, things that we would now think of as or know to be malaria and yellow fever and so forth. And this connection was born of trade. So you had European soldiers, but also European traders connecting to ports in West Africa, going there, dying in droves, and this kind of mythology arose that this was a particularly dangerous place. And so, for me, from in historical perspective, one of the most striking things was the kind of white man's grave redux in the treatment of this particular problem. The bushmeat question, which I think is a really interesting one to take on as well, is one I imagine everybody has a lot to say about. But I think the context of fevers first, not necessarily hemorrhagic fevers, but fevers that were understood to be affiliated with this particular environment that was particularly dangerous for travelers coming in, is the kind of foundational interaction, I would say, from the European perspective. I don't know, I mean, Deb, you've been nodding, and Guillaume, you look skeptical.
Want to take it on, Deb?
Oh, yeah, I'm wholeheartedly agreeing with Mary. In the 19th century, it's more about European body, fear of Europeans being sick. And what changes after the bacteriological revolution is increasingly the discourse changes to African bodies being the problem, and especially African children. If you look at malaria, and Robert Koch discovered that children are far more likely to transmit the infection than adults, and then there becomes sort of the clash of weak white bodies visiting a place that is full of diseased children, but full of diseased Africans, and then you get into issues such as segregation and forceful separation and invasion of people's homes in order to contain the threat. So I think there's a long tradition of treating Africa as a disease place and a series of bad responses to that on the part of the European. I mean, it is true that when you look at the statistics in the 19th century, lots of Europeans died who went there. And I think Philip Burton, he had a line in one of his books, something about it wasn't as bad as they thought it was, but it wasn't exactly going to the spa either. It was it was a dangerous place, and they didn't quite understand why. But even once they identify the mosquito and the fly, the responses to it continue to perpetuate certain tropes about dangerous bodies, particularly African bodies.
And if I could jump in just real quick on that, one of the things that I've always thought was very interesting about that move to sort of classifying African children's bodies and understanding these sort of disease transmission patterns in particular ways is that it's not about race, we know now. It's about first exposure to particular diseases. And so the people who are the most vulnerable are those people who are in their first exposure to malaria or to yellow fever. And so in terms of who's dangerous and who has the highest parasitemia in the bloodstream, the Europeans were just as dangerous as those African children. Epidemiologically, but it was understood so differently.
Well, and that's the irony of segregating the Europeans in the hills. They were just as likely to become infected in the hills as they were down in the city, and then they were great reservoirs for the perpetuation of the disease. So it was the exact wrong response And in part, it's this kind of wrong thinking inspired by this erroneous racialization of the disease. Yeah.
Right. In Freetown specifically, yeah.
Yeah.
Now, I should mention that because we have muted you, if you do have something that you want to contribute, feel free to wave your hand and we'll get to it.
Jess
But
wants it.
I think Jessica's ready.
Okay, I'm unmuted. Okay, I think this article is really interesting. So I printed off the Washington Post article, and it says the long and ugly tradition of treating Africa as a diseased and dirty place. And so, in addition to that, I would also add something that we see both now and that we saw in the colonial period was the portrayal of Africa as someplace that was not modern. So now we're talking about how Africa has this outdated health infrastructure. They're not modern. They don't have the capacity to deal with these diseases. I think that connects not just to health infrastructure, but also the way that health and politics connect. So I'll give you one example. After 1946 in the French Empire, everyone gets citizenship. So in the late 1940s in Africa, everyone is a French citizen or a citizen of the French Union. And so one of the things that you see Africans doing is saying no to vaccines. They're saying, one, we don't want to be vaccinated against our will, and we also don't want to give birth in your European maternity hospitals. We want to give birth in our own home, and we choose not to be vaccinated. We are citizens now. You can no longer coerce us to be vaccinated against our will. And what's really interesting is then you have public health officials saying, look, you have fundamentally misunderstood what it means to be a modern citizen. Being a modern citizen means that you get vaccinated, you give birth in modern European hospitals, and that saying no to these things shows that you are fundamentally not modern. You're not ready for these political rights.
It's an interesting comparison when you think of the sort of modern anti-vax movement and home birth movements that are just very progressive in oftentimes, as well as conservative. Guillaume, did you have a comment?
I think just to add a note of ambivalence on this history, because I think there's obviously this major question of the African as a reservoir of virus, as a threat, as a security threat in a way that very clearly is constituted through the malaria issue in African cities at the beginning of the 20th century. But this idea also coexists, and especially in the Western colonial imperial medias, with another image of Africa as a continent to save or to redeem. And obviously the African child, the history of the African child in the media is very ambivalent, because there's this idea of a threat, but it's also a much more desirable figure where Europe can prove its capacity to save the children as it is. So there's an ambivalence of Western gaze towards Africa when it comes to health, a strong ambivalence, and in a way this Bushmeat terrible cover is one pole of this ambivalence.
Yeah, that's terribly interesting, and I do want to get to that too. But first, before we leave the topic of the sort of Bushmeat thing, I think the search for origins for what caused this this particular outbreak has been some of the focus of Western media, although I'd argue that most of it was about how do we keep it from spreading to us. But my question, I guess, is, the sort of tracing it to African bushmeat, which there's, from my understanding, there's no evidence that actually could possibly have been the conduit. But is this a typical trope? Is there sort of blaming these kinds of what are seen as, bizarre African practices or something?
Sure. One of the things that I've been talking about with my students, I'm teaching a course on disease and health in modern Africa right now. We say bushmeat instead of wild game.
Yeah.
Venison could be considered bushmeat, but we don't call it bushmeat. We call it wild game. And I think that's my sort of first corrective in terms of the way that we speak about these things. But I'd be interested to hear what everybody else has to say, especially about this question of origins, because it's also about how you frame human-animal interactions, and those as being static in a particular moment, or as kind of changing over time in ways that I think is an interesting epidemiological problem, but also ties into these sort of cultural readings as well.
Maybe you want to take that on, Guillaume?
Yeah, I think there's this idea of transgression. It's the Bushmeat narratives really makes emerging diseases as a product of a transgression of something that is implicitly abnormal, which is eating meat that should not be eaten. I mean, so it's always implicit, but it's very strongly there, and it was. I mean, it's something that really came out, I think, in the last 15, 20 years with the issue of the origin of AIDS, and then in this case with Ebola. But one important thing to say about the emphasis on bushmeat is how pointless it is in terms of public health and even of health security. I mean, the big question with this Ebola epidemic is not the origin of the epidemic, which is at the same time obvious and not important. The big question is how did the epidemic manage to get at such a scale? And this question is only a question of human-to-human interaction. And very clearly, there will be other epidemics of other bugs coming from monkeys, coming from apes, coming from bats. But and it's not a limiting factor. I mean, we keep on exchanging pathogens with these animals. It's totally banal. So the emphasis on bushmeat is really pointless, and it really obscures the important questions in terms of epidemiology.
Deb, please jump in.
Yeah, I was just thinking about this in relation to, I really agree with Guillaume and the SARS epidemic in Toronto, and I live in Toronto, so, and there was all this obsession with where did SARS come from, as if it always has to come from somewhere else. And I know, Mary, you teach it this way as well. I mean, why? There's a lot of emphasis on finding something or someone or some practice to blame. And in Toronto, I think that these origins questions really reveal kind of otherwise hidden pathologies or assumptions in a given society, or a society looking on. In the SARS case, it revealed a really nasty xenophobia towards immigrant communities, the Asian community in particular, in Toronto, which had not been a particularly obvious set of prejudices, but as soon as the SARS debate began, it was, well, where did it come from? It must have come from, it came from Asia. It must have come via Asian immigrants. And there's a real blame game going on. And it's interesting that this is where we go, instead of, as Guillaume says, saying, where did we fall down in terms of the spread and the transmission and that kind of a focus? So I don't know. Why do we go there? We're looking for somebody to blame? I mean, is it that primitive?
It's a good question. But I'd also like to talk about this question of how did it get to the scale that Guillaume sort of brings up. I mean, the transmission sort of, it's declared out of hand, it's declared unmanageable for a while, and while it seems that, some of those reports have died down a bit, there's still a continuing problem. I know you're all historians, but if we can start with sort of what did sort of lay the foundations for this epidemic to get out of control. All the European coverage is all about how, well, we can stop it, don't worry. And that was the U.S. coverage too. It's like, don't worry, we're good. We can stop this. We have modern, developed healthcare system. But so what's going on in these regions that they're pointing to in Western Africa that's maybe, is there valid concerns that there's something specific and endemic to this region of Africa that's causing the problem?
Like, there's a sort of resignation as a historian, and sort of which part of the 20th century do you want to discuss first, in a way. Right, I don't know. I can see Guillaume smiling. And I think you can periodize this in a variety of different ways. My instinctive reaction, and I'll let Guillaume speak more about this because it's his writing that I'm thinking about, is about structural adjustment and economic policies within the last 30 years or so. Do we also think about environmental change? There's a fairly active debate among epidemiologists, historical epidemiologists, and others about whether we can understand this as being the result of environmental change brought about in the last few decades, or do we think of origins and public health infrastructure as being something that we need to go back into the earlier part of the 20th century about? I mean, I think it's a question of emphasis. I'm not gonna say one absolute answer, but I would frame it that way too.
I'm making sure that I can see. Yeah, so Guillaume, if you wouldn't mind.
Yeah, even more than which part of the century do we want to discuss? It's also to think of this French historian Fernand Braudel. It's also which kind of temporality, and we're speaking of different temporalities that in a way prepared the way from this epidemic. And so I think the short-term temporality is the response, and I mean we have now enough elements to say that the response, especially at the WHO, was extremely slow and shy, and that's certainly the main causes of the current epidemic is that it's not been contained while it was containable. Then the second temporality is the temporality of recent health policies, and how paradoxically the emphasis on emerging diseases and global health security as the priority actually prioritized actions that let health systems collapse in a way. That how the push towards shining global health interventions actually paved the way for this epidemic by letting entire health systems go down. And then the third temporality is certainly, as Mary said, the structural adjustment, neoliberal reforms, and the collapse of the states that also prepared the way to civil wars in this region. And maybe a fourth temporality is a longer-term history of healthcare, and also things like the specific trans-border environment. That is it's a very specific political environment, the region where the epidemic emerged, which is a triple point of three countries, and it posed a very difficult questions for disease control because people moved across the border, and it's a very artificial environment. It's a land, a kissy land that is separated by a series of frontiers, and this specific ecosystem of frontiers, made of frontiers, complicated enormously the response.
Oh yeah, I was actually going to throw it to you, Jessica. I was wondering what you had to say about this.
I mean, I think that Guillaume is right. And actually, I just wanted to say a little bit about the World Health Organization. I just gave a presentation about this last week. But so the Ebola epidemic begins in March 2014, and it's not until August 8th that the World Health Organization declares their official term is Public Health Emergency of International Concern, PHEIC. And this is how they designate a specific protocol for dealing with the disease, and they've actually only done it 3 times in history. So the flu pandemic of 2009 and then the upsurge in polio cases in spring of 2014 are the only other times they've declared an international public health emergency. And I think that by waiting so long to declare one, I think that really kind of held the whole international community off, maybe the exception of Doctors Without Borders, on coming up with a kind of global solution to this. And my own work is looking at the WHO historically in Africa, and I see so many parallels with the way that international health organizations let themselves be run completely by politics, instead of putting the health concerns of Africans first. So when the WHO gets set up in the late 1940s, early 1950s in Africa, the primary concern of everyone sitting in that room is, do we even allow international personnel to come to Africa? Because what if they talk to Africans about self-determination? They're not concerned at all with malaria transmission. They're not concerned with TB vaccinations. They're concerned with, well, if we let a malaria technician from the Soviet Union or Denmark or the United States come and teach someone in a village how to spray DDT in their homes, what is that conversation that's going to happen between the American technician and a Senegalese person about the political status of Senegal or of Mali or somewhere else? So, I mean, I see this connecting back to a really long history of not putting health concerns first and instead putting political concerns first. So the Associated Press put on their website all of the emails about this decision not to declare an international public health emergency. And they cited, they were worried about tourism. They were worried about people doing the pilgrimage from West Africa to Mecca, that it might create, bad ideas about Africa and it might stop people from trading. So all political concerns and not thinking about, what are the actual public health ramifications of not declaring an international public health emergency.
But then at the same time, there was this moment where the Sierra Leonean minister of, official, I shouldn't say ministers, an economic official, and I think this was right after the flights into West Africa were cut off briefly. Just basically said, look, you've now isolated us from the rest of the world, like that, and was calling attention to the fact that the economic ramifications of this, in the long run, would be vast and would be long lasting. Because of, I think that what you're pointing out in terms of the image, but also just the day-to-day relations of trade and commerce. Because, I mean, Freetown and Monrovia and Conakry are massive regional centers of trade and commerce and travel and everything else. This is not an isolated place in an isolated region. And I think that part of it is an important element in that story and those concerns. But it seems to have played out in a way that is the kind of worst case scenario again.
Right. And I think that what ended up happening is it ended up having economic ramifications anyway. It ended up having ramifications for tourism. And I think that getting in there at the beginning and saying this is an emergency and we all need to deal with it, I think maybe could have stopped the problem sooner and maybe limited those long-term economic ramifications like off into the future.
Interesting. I'm fascinated by this idea that in the early years of the World Health Organization, they're more concerned about stopping the spread of decolonization than stopping the spread of disease. Right. That's pretty fascinating. Let's take a second and go back a little bit more. Let's pan out a little bit more. I wanted to know if you could talk a little bit, I think each of you, about the relationship. We're talking a lot about sort of health and politics, and if we take it back, what was the relationship between health and colonialism in the colonial period, and how did it change over time? How? It's a big question. Who wants to?
It is a big question.
Who's ready to dive into that? Go ahead. Please.
Wow. Why did I volunteer? So, my work starts in the late 19th century, and the interest in the microbiological origins of disease, but the call for it is really amongst a group of European officials whose presence is growing in all over sub-Saharan Africa and North Africa for that matter, and they want to protect themselves. So the origins of it is they are not particularly interested in. There's no such thing really as global public health. It's more, how do we protect ourselves so we don't die when we go there? And so tropical medicine is very much about protecting Europeans. And then it becomes, at the turn of the century, particularly with the sleeping sickness epidemic and the ongoing serious problem of malaria, it becomes, how do we protect workers who work for Europeans? So those Africans who work for the administration, laborers who are working on plantations, who are working on at the docks, in the warehouses. How do we stop them from becoming infected with the diseases that affect our productivity? And so and they're quite open about this. I'm working on a paper right now about corporate sponsorship of medical research, and there's a lot of money that corporations in Britain, for example, put into the Liverpool Tropical Medicine School expressly because they're trying to protect their workers and they're trying to protect themselves. And they're not particularly interested in making healthcare widely available. They kind of see it as the government's problem. And the government says, we don't have any money. That's not our priority. We want to. So it's a pretty slow realization over time that, and it's pretty self-serving that by protecting Africans, we protect ourselves. And so that's the birth of it is really desire for a greater European presence in the tropics for the extraction and protecting the people who can make that happen.
You were nodding a lot. Do you have something to add?
So yeah, it's a way of listening for me, nodding.
Well, then you read.
I think then an interesting moment is the post 1945 context with this new framing of disease as an obstacle to development, and health as the key to economic rise. And so there's a new, more economic framing of disease. So that is not raw instrumental care for the worker, but it's something more general. Is that if we imperial power, if we the US wants Africa to become a market and to become a real economy, we have to fix tropical disease. And by coincidence, we now have, thanks to war research, we now have technologies, and so there's this post 1945 climate is a turning point because of new technologies such as DDT and antibiotics and other drugs, and because of this new understanding of disease as an economic issue, and then colonialism. Colonial medicine, in a way, re itself as a tool of development in the post 45 years.
Jessica.
I think that Guillaume is exactly right, that there's something really important that changes after 1945. And something I'd want to add to that is the question that I'm looking at is how does colonial medicine change after 1945 in relationship to the creation of the UN and the WHO? So one of the things that the UN does is they collect reports from all of the colonies on social conditions, educational conditions, and economic conditions. And as a part of social conditions, they're looking at health. So the French are saying, from their colonial position, we want to show the UN that we're developing health, that we're training more Africans as doctors. And from the perspective of the UN, what they want to see is that the French are preparing Africans for eventual self-determination, that they will have the health infrastructure to be independent. From the perspective of the French, what they're really saying is, the UN wants to talk about development. That's what we've been doing all along. We called it the civilizing mission. Now, if you want us to call it development, we will. But we've actually been in Africa developing them all along. We don't need foreign technicians. We don't need foreign technical experts to come to Africa, talk to Africans, interact on the ground. We already are doing this, but we would really appreciate some kind of international funding to support the programs that we're already building. It's not a question of skill, it's a question of need.
Yeah, before we move from that, I just wanted to say that this is interesting because it maps on to, the creation of sort of the EEC and supranationalism with the sort of beginning stages of integration. And when you look at the people who were directly concerned with early European development policy, it's the same people that were the, colonialists and in charge of colonial policy right before. So there's this really nice continuity for those of us who are interested in these questions. And Mary, you had something?
I was just going to say, also I think the one thing that is a key challenge is this issue of transitioning from, as Deb has said, thinking about particular populations who are of particular value, economic value, and then Jessica and Guillaume's points about this transition forward, that rural health and rural health infrastructure remains a key challenge, and I would say a key challenge that is undertaken in a variety of very haphazard ways, in some sense, as a general policy. During the colonial period, we had targeted vertical campaigns, which those of us who work on sleeping sickness think a lot about. Targeted vertical campaigns or immunization campaigns, various attempts But the development of infrastructure or the encouragement of expertise and training of Africans and of African personnel is not something that's really taken on board in that colonial period, which sets up a particular immense set of challenges in the post-colonial period that I think are an important question to keep in mind, because even though we have a sense of independence as this incredibly crucial moment, there are a lot of institutional continuities that have to be sort of taken up and shifted and reworked and restaffed, and there's a quite in some ways a kind of vindictive history that we know of from that process of decolonization of removing capacity almost punitively from independent nations, and then of a kind of a steeper learning curve than might have existed otherwise in terms of putting into place health infrastructure, staffing those hospitals and health centers, not to mention expanding rural health infrastructure out into areas outside of the cities. And it's precisely those rural spaces that are then framed as, in our time, as the most dangerous and pathogenic and, as Guillaume said, transgressive spaces where these diseases are coming out of to get everybody else. The idea of an emerging disease and not just a new disease, I think, is a really important rhetorical distinction that's being made about precisely these kinds of spaces.
Can I ask then? Guillaume, go ahead.
Just because we've not said something which is important in terms of what was the relation between health and colonialism, and because it's an obvious thing, is that health over the 20th century becomes a value, a secular value that is shared across the West, and it becomes also an important question of image. And as early as the interwar period, health action in the colonies is a benchmark of colonial goodwill, of colonial expertise, and so health is very important in terms of rivalries between Germany, France, and Britain, just as a matter of image, as something where colonial power can demonstrate their goodwill, their technical capacity, etc. It's a moral value, and it's also a domain of image, speculation, and creating just a good image.
That's interesting. It brings up a point that I was thinking about, and I posed it in the questions, and it's very much related to what you just said, is this, in this sort of contemporary period when we have these highly publicized outbreaks and epidemics, they prompt questions and coverage about healthcare inequality and these ethical questions about public health being a human right, as you point out. And I was wondering if that was a modern phenomenon, a product of our age. And it seems there might be some kind of things we can trace in the colonial period, but seeing it as this sort of moral question is the civilizing mission and Europeans uplifting. But is there another way that we can see such concerns evident in the era of imperialism, or are they more modern than that?
I think if we're thinking about human rights discourse or health as a human right, that's something that really comes out of, well, I mean, Jessica, maybe you can speak more about the immediate post-World War II period, but I'm thinking about Alma-Ata in the 1970s and in the late 70s and into the 80s about the idea of health for all, and this is something that an international community will guarantee or will move toward guaranteeing. That's then, I think, certainly undergoes a series of shifts in the 80s and 90s, but I think reemerges in particular ways in 2000 with the Millennium Development Goals. And so I would think about that kind of sense of, and I don't know if I'm quite speaking to your question, but of the kind of lineage of that as being more in the post-colonial period as a result of a wider international conversation, and a human rights conversation that certainly is rooted, at least in our sense of it, in Europe. I mean, there are origins of these ideas about human rights and health as a human right that actually come out of other spaces. There's some really innovative work going on about the Ottoman Empire and Ottoman definitions of rights that are feeding into that world. I know, it makes you raise your eyebrows. It's really cool stuff because it's not the narrative that we have. But I think of this idea of health as a human right, in particular access to resources, as being of that period within some of our lifetimes. certainly, and being more modern, even if it has these older roots.
Jessica?
Yeah, I think that's right. I think it does come from the WHO, but I think I would actually trace it back even to the origins in 1946. So, in the preamble to the WHO Constitution, it says, I'm going to read it to you. The enjoyment of the highest attainable standard of health is one of the fundamental rights of every human being without distinction of race, religion, political belief, economic, or social condition. So it's in the WHO Constitution, and I think that might be the first time I've ever seen it referred to as a right.
Deb, did you have a comment?
Oh, I mean, I'm going to say something that I think is pretty obvious, but there's no discourse about health as a human right before 1914, and I don't even think really before 1939, before the Second World War. I mean, the human rights movement is in its infancy before 1914, and it's primarily focused on the issue of labor and slavery, and then those people who are really obsessed with anti-alcohol stuff. The Congo Reform Association is pursuing problems with labor and working conditions generally. But I do think out of those movements comes a for the way people are living as they're being exploited by large European companies. But the health is, I mean, I had a master's student working on this, and she dates it in British Somaliland, which is where she was working, into the 1950s, really, and that it's as much about a pushback by Africans themselves making demands at the same time as they're making demands for independence, as it is about Europeans slowly coming around to the idea that maybe they should be providing these things. As Africans gain a greater voice in their own in their own colony and then eventually their own country, that this becomes a much more pressing issue for the Europeans. I don't know.
I think that's a good point to make too. I mean, when I'm thinking about the sort of health as a human right, I'm glad to sort of thanks, Jess. I mean, that sort of thinking about the WHO preamble, which everybody's talking about right now, I think is really interesting. But there's also this issue of agency and of sort of, I'm thinking of labor unions and urban workers making particular demands that colonial administrations fulfill particular promises in the immediate post-war period around this topic of development as it's understood in a very broad sense. So I think that's a really important. We talk a lot about image and a lot about response and a lot about sort of the appraisal of African problems, and it's really essential, I think, to bring back into the conversation always the extent to which there's agitation and movement and advocacy on the part of people to change things in particular ways.
Yeah, I was actually going to I wanted to take this time. I know that people are getting ready to go break to do classes, and so I wanted to give a chance to our audiences to ask a question. I'm going to start here in our room here at Pitt, if anybody has a question here, but be thinking in Illinois and Florida, if you also have questions, and let me know. Did somebody have a question in this room? Yeah.
Please introduce yourself. I want to say a word. My name is Mustafa. I'm a physician from Nigeria and a graduate student in public health. So from the little I came late for, so from the little I heard around the Second World War, what happened with decolonization of Africa is that there is also a commodification of health. Mm-hmm. Health is viewed as something you go into a hospital and get. Mm-hmm. So the idea of bringing health to Africa is going there and building a hospital, going there and taking doctors, some miracle surgeons that will go and cure whatever disease it is that is in Africa. So it's not unique to Africa, but it is this interpretation of health as a commodity, as something you go to a hospital, to an institution, and that these saviors, Christ-like figures come in, starting from a missionary standpoint, will come and give you health and heal your whatever is afflicting you. While if you look at history, whatever gains in health were achieved not through the hospital, primarily through advances in many other socio-economic situations. For example, the most recent thing that happened in Liberia and Sierra Leone, it's not a coincidence that those countries were emerging from brutal wars that destroyed the entire fabric of those societies. And it's the same thing that our response to Liberia and Sierra Leone is to send troops, to airlift medical supplies to those people. It's practically airlifting hospitals to them and saving those people graciously. So I think it's our interpretation of health as something you give people, and Africa as a place that needs health, that sort of translates into the Alma Ata Declaration that health is a human right, so we need primary health care just like you need schools in every district, while also avoiding politically and diplomatically touchy issues that have to do with more complex issues that have to do with development, with conflict, with resources, with global trade, and so many other things.
The sort of obscuring, and I think this ties back in with what Gil was saying and what we've been thinking about in terms of the Bush meeting, the obscuring of the social conditions, right? The use of one kind of deliverable thing or trope or what have you that obscures the fact that there are these global inequalities that persist and social conditions and economic conditions, and the improvement of those is the thing that makes people healthier, right? Not just access to a tertiary hospital or something like that. Yeah, no.
Do we have another question? I think we have a question in Miami. Please go ahead.
I'm Isabel Perdor. I'm an MA student here in the history department as well as the newsletter editor for the center. And I'm going to maybe push you guys outside of your fields of study. I'm particularly interested in the Caribbean and Latin America, and I was wondering if you had seen similar trends or if any of you knew of similar trends happening in those areas.
Anyone? Did you hear the question? Oh, Deb, yes, please.
Oh, yeah, 3 hands.
I am well outside my field, but I'm working on something right now with a Caribbean historian on the Liverpool school missions before 1914, and they start going to the Caribbean. There's a big mission to combat malaria and other diseases in the Caribbean in 1908, and there's a big push into Jamaica, and it corresponds with British interest in developing the banana industry in Jamaica, and particularly the chair of the Liverpool School, Alfred Jones, who has an intense financial interest in this, in promoting this, and so he's very much pushing for tropical disease research into the Caribbean for this reason. And so what we're trying to work out now, and there's not a lot written on this kind of thing, but how policies and ideas that are developed in one place it's assumed that one can transfer them almost wholesale to another place without, and this ties into what you were saying, Mary, without recognizing the specificity of a particular time and place and the political background and the social background and all of the things that make malaria different in Sierra Leone than it is in Jamaica, and yet there's a sense that we bring the tools to fight this everywhere we go, and you could just drop down and solve the problem. And of course, it doesn't work that way. Can I also make a point? I'm so happy to see there's a Nigerian physician in the room. I actually have a question, which is, what is it that made Nigeria so much more successful than Sierra Leone and Liberia, other than, of course, the political dynamic? It seems like again, I read the Western media, but it seems that Nigeria has this wonderfully robust grassroots public health system, and that seemed to have made quite a big difference there. So anyway, I just asked a question.
Yeah, so in Nigeria, what really happened was that the most important thing in disease control is not a hospital, it's surveillance, it's the network, the infrastructure of finding those cases, tracing thousands of contacts and following them up. And Nigeria has been doing that for well over a decade through the polio control. So Nigeria had a polio problem, so it has an intensive polio surveillance program, so which practically goes to these remote areas, tracks every report of a suspected polio case, which was essentially transferred to the whole system, the whole infrastructure got transferred to the Ebola investigation. So it's practically going out there looking for people that had signs of a disease, and even if you don't treat them, you isolate them, they might live or die, but they will not spread the disease and eventually. So from a public health perspective, health clinics are part of the solution, but they are not the most important part. The most important part is identifying exposed people and isolating them at an early stage, which Nigeria having to do well.
And I would also say, just to the Caribbean question, I think that parallel is or that comparison is really an important comparison. I mean, my first thought, and it's partly just because I've been thinking about this based on other conversations today, is around, I mean, some of the parallels that you could think about in the Caribbean context would be with regard to the Rockefeller Institute and Rockefeller Institute health programs in the earlier part of the 19th century. And there's a sort of growing literature on parallels between the Rockefeller and the Gates Foundation in terms of how we understand non-governmental organizations with a lot of sort of clout and power, and how they move into these new areas. So I think if we're concerned or concerned with the historical parallels in the Caribbean as opposed to thinking about Africa, that's one important register to be operating on. But I think there is also, I mean, there is a distinctly racialized discourse of the Caribbean as an origin for different kinds of diseases that could be threats to the U.S. Or to the rest of the world. And so I don't think we can take for granted that just because it's in the Western Hemisphere, and this is not going to be anything surprising to you, but that the Caribbean is somehow considered so different than African context, or maybe than South Asian context, because partly it's tropical, right? It's understood as being tropical, but also because of racialized readings of health and disease that emerge out of the 19th century, if not before, that are applied to Caribbean contexts in particular ways. So, and then there's American Empire, which is another ball of wax, but I think I can see you smiling. You're very, very small, but yeah.
Just to give a quick example from my own work was that just made me think of all this is sort of, I look at the foundation of penal colonies in the French overseas empire, and they originally target French Guiana for a variety of reasons, but in around about the 1860s there's an outbreak of yellow fever, and basically, and they flat out say this, basically they decide, obviously Europeans cannot live in this colony. We're abandoning French Guiana. White people can't survive in this colony. We're only going to be sending our Arab and African deportees to this colony, and we will send the white deportees and a couple of other people to New Caledonia, which has a much healthier climate and is sanitary for Europeans who are too delicate to withstand the tropical environment. In more modern periods, you see, is French Guiana still a department of France? You see this kind of fight, like, you can't fit us into development policy, but you can't also treat us the way you do with metropolitan policy. We have this unique condition being where we are and being sort of the only gateway to Europe on the South American continent. So you get this interesting kind of bizarre sort of understanding of the specific nature of their health concerns. Again, the problem with the local.
Thank you.
Jessica.
I think I'm muted. Okay. I mean, I can actually, just as a sort of anecdote that maybe ties both of those two questions together. When the World Health Organization was founded, it was broken into 6 regions. I don't know, is there a way I can share my screen with you guys?
Yeah, if you share there should be a little button that says share content.
Hold on, share screen.
Yeah, share screen.
PowerPoint. Can you guys see that?
Oh, we could for a second.
We had it for a second. We needed to read fast.
Yeah.
Doesn't work?
Oh, hit receive. Can you click on receive content? Just click content. Yeah. Oh. Oh. We should stop ours. Yeah. Can you try one more time? And I think we need to receive. There
Yeah.
should be a way for us to receive.
Oh, it just flashes on us.
Okay, if you can't see it, that's okay.
Sorry.
So, it's okay. Can you guys still hear me?
Can you unshare ours?
Okay, well, I was gonna show you a map of the regions, but that's okay. So when the WHO gets founded, what the French actually say, so we always think of this saying about the British Empire, that the sun never sets on the British Empire, that they've sort of covered the entire globe. Well, so the French actually had colonies in all 6 regions of the WHO, which was going to mean that they were going to get to be on the regional committees for each of these 6 different zones. And what they said, oh, this is great for us. We're going to get these 6 awesome markets for French medicine, French technology, French expertise. And they definitely had the idea that all of these technologies and sciences and medicines they developed in Africa were going to be immediately transplantable to the Caribbean, to the Western Pacific, and to these other regions of the world that they considered, as a few people just said, to be quote unquote tropical.
Interesting. I wanted to give a chance. Is there a question in Illinois before I give a chance?
No question right now. Thank you, though.
No problem. Thanks. Well, this is a great discussion, and I'm sure it could just go on and on. But we do have to reach an endpoint at some point, and the audience is starting to, we're reaching a little bit of an attrition because people have to go to classes. So I want, before we get too rushed, I just wanted to thank our panelists. Jessica Guillaume, who's joining us from Paris time, so it's evening there, and probably cutting into dinner time at a certain point. Mary.
Beer time.
On my side. And Deborah. I'd also like to send a special thanks to Christine Cayley in Miami and Matt Rosenstein and Sebnem Osman for their coordination in Illinois. And to our team here in Pittsburgh, especially our director, Ron Linden, who was here at the table, and Kate Bowersox, who is keeping us going on the technology side and helping to coordinate everything. And thank you all for joining us and for what was a great conversation. I really appreciate it.
Thank you.
Welcome you again for a follow-up sometime.
Thank you. Thank you.